Assalamu alaikum and good. Dear all, we are going to start urogynecology part 1. Is my voice clear?
Yes, ma'am.
Okay. So, urogynecology is a big part. So we have divided into two parts. Today we are going to discuss on urinary incontinence and urodynamics and related talk articles. So to know detail about urogynecology, first we have to know about the anatomy of the urinary tract. So what is lower urinary tract? Lower urinary tract comprises the bladder, urinary bladder, urethra, and lower part of ureter. The important thing here is the bladder contains a specialized form of muscle, that is detrusor muscle. We all know about it. So this detrusor muscle is responsible for the function of the bladder. We know the bladder has two major functions, that is storage of urine and voiding of urine. This function is maintained by the detrusor muscle. And how this function is maintained? Here, this picture shows the nerve supply of the urinary bladder. You know, the bladder is supplied by sympathetic, parasympathetic, and somatic nerve supply. Sympathetic nerve is supplied, sympathetic, that is thoracic 10 to lumbar 1. What sympathetic nerve do? They are responsible for storage function because sympathetic nerve causes relaxation of the detrusor muscle. So when detrusor muscle become relaxed and the urethra become closed, so urine gradually collected from the ureter inside the urinary bladder and gradually the bladder become filled. So this is the storage function and that is maintained by sympathetic nerve. So these information we need to know and we need to memorize it because without knowing this information, we cannot understand the urodynamics. So how we can memorize it? Sympathetic for S, storage for S. So sympathetic nerve is responsible for storage function. Now the parasympathetic. Parasympathetic is responsible for voiding function. So parasympathetic is, we can memorize it by P. Parasympathetic is P and parasympathetic causes P, that is voiding. And this function is maintained by pontine micturition center. So P for pontine, P for parasympathetic, and P for P. So this is how the voiding function is maintained. So bladder muscle, detrusor muscle is contracted and at the same time urethra is relaxed, means urethra open. So voiding occurred. This picture shows the this picture shows the filling and voiding phase. So here we can see the reciprocal contraction and relaxation of the detrusor muscle. In the first picture, the detrusor muscle become relaxed and the sphincter contracted, so the bladder gradually become filled. And in next picture, the urethra become relaxed and detrusor muscle contract and it is a voiding phase. So what are the lower urinary tract symptoms? This slide is very much important. Here we can see the lower urinary tract has storage symptom, voiding symptom, and post-micturition symptoms. And the prevalence of women with lower urinary tract symptoms is 39 to 67%. And this is an important exam question. This question has come once previously. What is the prevalence of lower urinary tract symptoms of women? And the most important is storage symptom. It is another important question. It can come as SBA. So storage symptom is 59% and 20% voiding symptom and post-voiding 14%. Now, what are the storage symptoms? The storage symptoms are urgency, frequency, nocturia, and what is the what is nocturia? That is nighttime voiding. If more than once nighttime voiding, it is called nocturia. And urgency. Urgency is sudden compelling desire to pass urine, just like the patient feels I need to go to pee and he or she cannot wait. This is urgency, and incontinence is involuntary leakage of urine. So these are the storage symptoms. These definitions are very much important to know, because in exam they will give a scenario. They can give the patient has a frequency of 8 times or nocturia for 2 times, or the patient has urgency. So what will you do next? So if you want to understand the question, what they want to say in that case, so these symptoms you have to know very well. Now the voiding symptoms. The voiding symptoms are poor stream, intermittent stream, hesitancy. Poor stream, we all know, the slow stream of urine. Intermittent stream is stop and start, urine stop and start. This is intermittent stream. And hesitancy is difficulty of initiation of urine. The patient has urge, he or she wants to void, but there is difficulty in starting the pee, that is hesitancy. And the next one is post-micturition symptom. There are incomplete emptying and post-micturition dribbling. Incomplete emptying, we can, if the patient come after voiding, and if we found the residual urine is high, residual volume, so it is incomplete emptying. And post-micturition dribbling is common in case of urethral diverticulum. So these all are the symptoms as we have discussed. Storage, voiding, and post-micturition symptoms. So this slide is very much important. Here it is the summary of what we have now discussed. What are the common symptoms of lower urinary tract, that is storage, voiding, and post-micturition symptom. What are the common symptoms the symptoms affecting the women between 39 to 67%, means it's around 75% of the women have at least one symptoms of lower urinary tract in their life. So this is important exam question, I told you. Storage symptom, the most common is lower urinary tract. Storage symptoms is the most important lower urinary tract symptoms. And storage symptoms are due to involuntary detrusor contraction, and voiding symptoms are due to outlet problem like urethral stricture or kinking. Now the incontinence. We know incontinence is the involuntary leakage of urine, and the most common form of incontinence is stress urinary incontinence. And incontinence, as we told, its prevalence increases with age. But stress incontinence usually occur in the middle age, because the stress incontinence occur due to, it is an anatomical problem. The urethral hypermobility is the main cause, or sphincter defect. So if, the most common cause is childbirth or trauma during childbirth. So, so middle age is, its prevalence is high in middle age. And the mixed and urge incontinence are prevalent in elderly age. So we already told what is incontinence, involuntary leakage of urine, but International Continence Society say involuntary leakage of urine during storage phase, it is the urinary incontinence. And what is stress or coughing? And urge incontinence, if the incontinence is immediately preceded by urge or sudden compelling desire to urinate that is difficult to delay, that is urge incontinence. And the mixed incontinence is combination of both stress and urge. Now, one important thing is overactive bladder. There are similar terms, that is urge incontinence, overactive bladder, and detrusor overactivity. So what is the differences between these? This information is very much important for the exam. So what is OAB, overactive bladder? Overactive bladder is this syndrome. It is not one symptom. It is a syndrome complex. What is this syndrome inside this syndrome? That is urgency with or without urge incontinence, with frequency, nocturia in the absence of urinary tract infection or other underlying bladder pathology. This is the definition of OAB, overactive bladder. So here we can see urgency, frequency, nocturia with or without incontinence. If the patient have symptoms of OAB, that is urgency, frequency, nocturia, but the patient do not have incontinence, it is OAB dry. if the patient have incontinence, that is OAB wet. That means if the symptoms of OAB is associated with leakage, it is OAB wet. If no leakage of urine, it is OAB dry. I hope I'm clear. So this is OAB. Now what is detrusor overactivity? Whenever a patient come with OAB, and we do a urodynamic test, and we found that there is detrusor overactivity. In urodynamic test, normally in filling phase, there will be no detrusor activity. However, if we found any detrusor activity in the filling phase, that is detrusor overactivity, and if it is associated with leakage, that is detrusor overactivity incontinence. I know it is difficult to understand, but it is understandable. If you look at this slide here, what is the difference between OAB and difference between detrusor overactivity? OAB is a symptomatic diagnosis. Whenever the patient have symptoms like urgency, frequency, nocturia, with or without leakage, this is OAB. And what is detrusor overactivity? Whenever the symptoms of OAB are proven with urodynamics, then it is called detrusor overactivity. Asma, are you there? Okay, so this is the difference between detrusor overactivity and overactive bladder. Now the classification of urinary incontinence. The urinary incontinence classification consists of stress incontinence, as we have told, urge incontinence, mixed incontinence, overflow incontinence, continuous or true incontinence. The other name is fistula, vesicovaginal or other type of fistula, urinary fistula. Others are urethral diverticulum, congenital anomalies like ectopic ureter, functional incontinence due to immobility, and temporary incontinence. So this information I have taken from Start2G. The major type of incontinence are stress incontinence, urge incontinence, and mixed incontinence. This is always a very important slide because so some questions have come from there. What is the most common type of stress incontinence? That is stress incontinence. And the percentage also important, it's 50%. This picture shows the difference between normal bladder and during stress and urge incontinence and mixed incontinence. If we see this and look at this picture, we can see in normal bladder, the detrusor muscle do not have any contraction and urethra become closed. So it is normal bladder. In stress incontinence, no change in detrusor muscle. However, the sphincter become open, and during raise in intra-abdominal pressure, this sphincter become open and urine leaks. So this is stress incontinence. In urge incontinence, there is problem in detrusor muscle. Detrusor muscle involuntary contracts. However, the sphincter is okay. And the bladder capacity gradually reduced because whenever small amount of urine collected, it comes out due to overactivity of the detrusor muscle. And in mixed incontinence, both of the characters may present. This picture shows normal bladder and what happened in stress incontinence. During raised intra-abdominal pressure, the sphincter became open, however, no change in the detrusor muscle. So what is urodynamic stress incontinence? Urodynamic stress incontinence is defined as involuntary leakage of urine during increased intra-abdominal pressure in the absence of detrusor contraction. So it is a urodynamic diagnosis. Whenever a patient comes with leak during coughing, sneezing, playing, exercise, urodynamically proven. That is urodynamic stress incontinence. This picture, I have repeated these things many times. This is very much important. Without understanding these things, you cannot understand the urodynamics. and what is the difference between stress incontinence and dynamic stress? Stress incontinence is a symptom-based diagnosis and dynamic diagnosis. And what is the difference between OAB and detrusor overactivity dynamic diagnosis? The symptoms are happened in stress incontinence. The most common cause is hypermobility of the urethra. It occurred in 80% of the cases, and the other cause is intrinsic sphincter defect. Hypermobility of the urethra occurred due to distress of the normal uretrovectomy. It mostly occurred due to injury during the old days. And normally the bladder and urethra become intra-abdominal organ and is above the urogenital diaphragm. So what happened due to hypermobility of the the urethra? This structure become sagging down. This structure, urethra become open due to relaxation of the sphincter muscle become open during raise intra-abdominal pressure. So this is the main stress in and the sphincter
আসসালামু আলাইকুম ম্যাম, এই যে একটু নেট প্রবলেম, তো আপনি মনে হয় রিমুভ হয়ে গেছিলেন। একটু আবার ফাইলটা শেয়ার করবেন।
আর আপু আরেকটা হচ্ছে যে 4টা ক্যাটাগরি যে বলছিলেন, ওইখান থেকে হচ্ছে একটু কথাগুলো শোনা যায়নি।
Okay. So I'm sorry for the interruption due to network issues. So we were in the risk factors of urinary incontinence. So the main risk factors are pregnancy, childbirth, and menopause. And so others are age, parity, smoking, BMI. BMI is a very important risk factors because obesity causes increased intra-abdominal pressure, which causes worsening of the mainly stress incontinence and also urge. And hysterectomy, what happened in hysterectomy? We ligate and we cut the ligaments. So there is damage of endopelvic fascia and nerves, which is responsible for incontinence. And diabetes mellitus is another condition that is responsible for the incontinence. It aggravates the condition due to neuropathy, which affect the bladder function. And menopause, we all know in menopause there is estrogen deficiency, which causes weakness of the pelvic floor muscles and the related organs, which is responsible for the incontinence, aggravation of the condition, and connective tissue abnormalities like Marfan syndrome and Ehlers-Danlos syndrome. So these are the risk factors. Risk factors, we have to understand, we have to memorize all the risk factors, because any question can come, they can give you the risk factors inside the question, like a patient with high BMI, like BMI 35, come with the symptoms of incontinence. So in that case, we can predict that this patient may have stress incontinence. So it is an important clue. Like a patient come after hysterectomy, or patient with diabetes mellitus. So if any question come, a patient with diabetes mellitus, if you it give you a clue, this patient may have urge incontinence, like this. Now the assessment for incontinence. How we will assess if a patient of incontinence will come, or if a patient with lower urinary tract symptoms come. So assessment start with taking history, focused history, detailed examination, and important investigation. The good thing is, for urinary incontinence, not so much investigations are required. History and examination are enough for diagnosis of the patient in most of the cases. So a detailed history we need to take. I'm not going to tell details, because a history part is not so important for part 3. It is most important for not important for part 2. It is mostly important for part 3. Just quickly I will go through. We need to take at first the incontinence specific history, like what is the type of leakage? Is it arch, stress, or mixed? For how long the patient is having the symptoms, and how severe the symptoms are. We can assess the severity by the amount of leakage, frequency of leakage, whether the patient use any pad, whether it affect her daily activities, anything that aggravate the condition, and whether the patient take any treatment or any investigations done before. Then whether the patient has any associated pelvic or urinary symptoms, like whether the patient has any prolapse or features of UTI, any hematuria, any voiding difficulty, whether it affects her sexual life. An important history is fluid habit. By fluid habit, it is important because it will help in management of the patient as well. How much fluid the patient take daily, and what type of fluid, whether the patient has any habit of taking tea, coffee, alcohol, and how frequently. Other histories are obstetric history. It is very much important for stress incontinence, number of deliveries, any difficulties during delivery, any complication during or after delivery. And the medical conditions are important, like diabetes, neurological condition, urological condition, because these are responsible for incontinence. Now, medication history is another important history, because if the patient take diuretics, the patient may have symptoms like urgency, because if patient take diuretics, they need to go frequently to the toilet for the urination. So this may mimic the symptoms of incontinence. And any psychiatric disease like depression, dementia, anxiety, that can contribute for abnormal voiding pattern. Any past surgery, the patient may have surgery for incontinence in the past. So this is very much important. Now examination, general examination, very much important is BMI. In abdominal examination, you need to check whether the patient has any abdominal or pelvic mass. Because if the patient have fibroid uterus, this fibroid may cause incontinence, because fibroid uterus may irritate the bladder. So the patient need to go to the toilet frequently. So it is not for incontinence, it is for the fibroid. So this is very much important to know. Now pelvic examination, this is important. In pelvic examination, we will inspect the patient first to see the condition of the muscles of the vagina, any signs of atrophic vaginitis or any signs of infection. Then whether the patient has any prolapse. After that, we will ask the patient to cough to see whether urine comes out. If we see that there is urine leakage with cough, so diagnosis of stress incontinence we have done. No further test is required. Next, pelvic floor assessment is very much important, because in management, we need to do pelvic floor muscle exercise. In that case, the tone of the pelvic floor muscle and contractility of the muscle, we need to know about the condition of the patient. Then neurological examination is another important thing. So these much are in history and examination. Now urine testing. Urine testing, we know we do, in our country, we do urine routine and microscopy and culture. However, in UK, they do urine dipstick. So what guidelines says? In NICE guideline, they says first they will do urine dipstick to see the amount of blood, protein, leukocyte in and glucose in urine. If the patient have symptoms of urinary tract infection and
Ma'am, actually, I have a question.
Yeah.
Our country, urine dipstick is possible, or any hospital do urine dipstick?
Actually, I haven't seen any hospital to do urine dipstick. Always we do urine routine and microscopic examination. I'm not aware about it actually. I think it
Okay,
is
thank you, ma'am.
it is not popular in our country.
Okay, ma'am. Okay, thank you.
Okay, you are welcome. So if the patient have symptoms of UTI and we found urine dipstick positive, so what we will do? We will send urine for culture and start antibiotic. We will prescribe antibiotic pending culture report. This is what NICE said. If the patient have symptoms but dipstick negative, then what we will do? As the patient is symptomatic, we should always keep in mind that if the patient is symptomatic, always we will give antibiotic. In case of symptomatic and dipstick positive, we will prescribe antibiotic. However, if symptomatic patient but dipstick negative, we can consider antibiotic and send urine culture. Am I clear about that? It is very much important because we will get question from this. Now, if the patient is not symptomatic but dipstick positive, in that case, we will send culture, but we will not prescribe any antibiotic or we will not consider antibiotic because patient is not symptomatic, only dipstick positive. So we will send culture. If culture is positive, then we will start antibiotic. And the other is patient is asymptomatic, dipstick also negative. So we will not advise for antibiotic or no culture. Am I clear about that? So this is in the guideline. If you have any query, you can go through the guideline again. So we can go for next slide. Now it is bladder diaries. What we will do next? So if you think what we have done till now, whenever a patient come with urinary symptoms, lower urinary tract symptoms or symptoms of incontinence, first we will take detailed history, then do the examination and do urine testing. So if any question come, what is the first investigation of the patient who come with urinary symptoms or incontinence? So the answer will be urine dipstick or urine analysis. And this is a very important exam question. Several times it came in the exam. Now, bladder diaries. It is also called frequency volume chart. What is bladder diary? Bladder diary is nothing but the amount of fluid the patient take and amount of urine the patient void. The calculation of this is the bladder diary. It is the initial assessment of a woman. It is used for the initial assessment of a woman with urinary incontinence. This is also a very important exam question. What is the initial assessment of women with urinary incontinence? So what is the initial test? That is urine dipstick or urine analysis. And what is the initial assessment? That is bladder diaries or frequency volume chart. So this will be encouraged to do for 3 days including both working and leisure days. And symptom scoring and quality of life assessment. This is also, we are not very familiar with this, but there is a validated urinary incontinence specific symptom chart and quality of life questionnaire when therapies are being evaluated, and it is important for part 3. This is a sample of bladder diary. It is not very much important for part 2. It's just for your visual assessment, how the bladder diary will be. Here, amount of fluid in 24 hours, the patient, how much the patient take, that is intake chart. And then this is the how much fluid, urination the patient void in 24 hours, and what is the how many times the patient pee and how many times there is incontinence, all need to be plotted here. Now, so we have finished the urine analysis, bladder diary. Now assessing the residual urine. The residual urine can be assessed in 2 ways, either by bladder scan or catheterization. The NICE recommended bladder scan because it is non-invasive. So these are the investigation or tests that required to assess a patient with lower urinary tract symptoms or urinary incontinence. Now, urodynamics. When we will go for urodynamics? What NICE says, arch predominant mixed incontinence, where initial assessment does not provide a diagnosis. There is mismatch between subjective and objective measures, significant voiding dysfunction, anterior apical prolapse with SUI, and history of previous surgery for SUI. So how we can memorize these things? In case of stress incontinence, before stress incontinence, when we will go for urodynamics, if there is arch predominant mixed incontinence, pure stress incontinence is not an indication for urodynamics. Remember it very carefully that pure stress incontinence is not an indication of urodynamic test. So mixed incontinence, which is arch predominant. And if the patient has stress incontinence, along with it, the patient has voiding dysfunction or anterior apical prolapse, or patient has previous history of stress incontinence surgery, these are the indication. 1 minute, please. Had a phone call. So I think it's now clear when we will do urodynamic test. Now cystoscopy, it is also a specialized test. We will never advise cystoscopy in every patient of incontinence. When we will do cystoscopy, if the patient has hematuria or pain and discomfort that guide us that the patient may have intravesical lesion. So in case of hematuria, suspected intravesical lesion, and evaluation of vesicovaginal fistula. In these cases only we will go for cystoscopy. Now the indications for referral to specialized. I'm not going through this. All these are in guideline. We have to read this and memorize these things because any case scenario can come from here. That the patient has suspected urogenital fistula or fecal incontinence, stress incontinence associated with fecal incontinence. So what we will do here, one option may be referred to specialist. So this type of question can come in the exam. Now, what is local MDT and what is regional MDT? So this I have taken from the guideline. You can go through it. In local MDT, what they do, they usually deal with primary cases like primary stress incontinence patient, primary overactive bladder, or prolapse. And if the patient is taking invasive medication, in that case, they will review these cases. And they collaborate with the regional MDT. So when we will refer the patient for local MDT, in case of or what patients deal by local MDT, that is primary stress incontinence, OAB, or primary prolapse, or when the patient take invasive treatment, they will review the patient. And another thing, if the patient has any other problem like the patient is obese, so you need to send the patient to another specialties like nutritionist. So this patient is reviewed by the local MDT. And they work with an established clinical network that has an access to regional MDT. So now regional MDT. Regional MDT usually deal with complex cases, like if there is any MASH related problem, or if the patient having repeated incontinence surgery, or repeated same site prolapse, or patient having coexisting bowel problem. These cases will be reviewed by regional MDT. And who are the members? These I have taken from NICE guideline. You will go through once. Nothing to actually say about this. You will go through it. Another important thing is, whenever the patient of urinary incontinence take any treatment like any surgery all these things will be registered in National Registry for Urinary Incontinence. This information is very much important. And what you will register: the NHS number, hospital and consultant identities, details about the procedure. If the patient is giving mash, in that case, details about the mash. If there is colpo suspension, what type of suture is using. If bulking agent is given, detail about the material and the date and detail of the any investigation for complication. All these things have to be registered. So this is the summary of what we have discussed till now. How we will assess a patient with urinary incontinence. The initial assessment include history and examination. Then we will do urine testing, then bladder diary, then assess PVR, post-void residue, and refer the patient for specialist according to their finding, and if required, cystometry, uroflowmetry, and finally the management. Very much important for exam. Now management. How we will manage a patient of stress urinary incontinence. There are other symptoms like bladder pain syndrome or chronic pelvic pain or many other symptoms. Similar treatment we usually give to the patient, and here we can see the treatment start with lifestyle modification. There are stepwise management, conservative management, medical management, surgical management, like this. So management of urinary incontinence also is a stepwise management, starting with lifestyle modification. If the patient is obese, BMI more than 30, in that case, weight loss, smoking cessation, and fluid management are the initial lifestyle management. Then pelvic floor muscle training. It is the first line therapy for women with stress urinary incontinence. It is a very important exam question. It several times came in the exam before. What is the first line therapy for women with stress urinary incontinence? That is pelvic floor muscle training. And sometimes they give supervised pelvic floor muscle training. If there is option, one is pelvic floor muscle training and another is supervised pelvic floor muscle training, so the answer will be supervised pelvic floor muscle training. How it will be given? 8 contractions 3 times a day for 3 months. And this is also very much important. We have to memorize it by heart. 8 contractions 3 times a day for 3 months. And cure rate around 40 to 50%. And if it is beneficial, the patient will continue it. If the patient going to the medical or surgical management, this pelvic floor muscle should be continued with it. Adjunct therapy, that is biofeedback or electrical stimulation. It is not for all women. It is considered for women who is unable to identify the muscle, which muscle she will be contracted. For this reason, biofeedback or electrical stimulation is required. And the other conservative management include devices. There are some devices I will tell you in details in next slide. And so in what NICE guidelines says, in lifestyle intervention, caffeine reduction, modify the fluid intake, and lose weight if BMI more than 30. And what do you mean by modify fluid intake? If the patient take 3 or patient brings 3 liter of fluid, so we need to tell her to curtail the fluid. She will take 1.5 to 2 liter of fluid in 24 hours. And if she take tea, coffee, alcohol, she need to curtail this. Now, pelvic floor muscle exercise. We already discussed 8 contraction 3 times a day for 3 months. That is supervised pelvic floor muscle exercise. This information is very much important whenever we find out any question of pelvic floor muscle exercise. We should look for whether there is any supervised, the term. If there is supervised pelvic floor muscle exercise, so this will be the answer of the question. Electrical stimulation we already discussed. Now a question, a 60-year-old woman, para 4, complains of urinary incontinence on cuffing. She is distressed on examination. Pelvic floor muscle tone appears to be grade 4. What is the next step? And what will be advised her at first line treatment? Here is the fallacy. Here the question I already told, what is the first line investigation or first investigation? That will be urinary analysis. What is your next step? That will be bladder diary. What will be your first advice as first line treatment? That will be pelvic floor muscle exercise. And if there is another option of supervised PFMT, in that case, supervised PFMT will be the correct answer. I hope I'm clear. Now, we started treatment with lifestyle modification. then pelvic floor muscle exercise. Now the patient is not improving. What we will do? Now we will go for surgery according to NICE guideline. So first line treatment after treatment of stress incontinence after pelvic floor muscle therapy is surgery. And the surgeries are colposuspension, fascial sling, and mesh, that is retropubic mid-urethral mesh sling. So what is the first choice of surgery? There is still controversy. Till now, the colposuspension is the gold standard. Then autologous fascial sling, and lastly, retropubic mid-urethral sling. Though we can see the sling operation is very much popular, but due to mesh complication, this operation is now banned in UK.
Ma'am,
So-
would you please tell me the colposuspension mean open or laparoscopic? The colposuspension means we not cut our any prolapse part or any SUI patient.
I'm telling you, this picture is showing the colposuspension. That is, it can be done either open or in laparoscopic way. So what we will do, we will go to the space of Regiers, that is suprapubic area by open or laparoscopically. Then what we will do, here we elevate this part, that is with absorbable suture, the suprapubic space. Am I audible?
Yeah. Yes, ma'am.
Can you understand what I'm going?
Yeah, ma'am. I can understand. Please, you
Yeah.
tell me details.
This neck
Yes,
of the
ma'am.
bladder is elevated. What happened in stress incontinence? The neck of the bladder become hypermobile, or it's sagging down. So this neck of the bladder become elevated, and with a stitch, it will be stitched with the Cooper's ligament in both sides.
Okay,
Like
ma'am.
there,
Okay. Yeah.
neck of the bladder will be stitched and it will be elevated, and it is stitched with the Cooper ligament so that it become elevated.
Elevated. Right. Yes,
Right?
ma'am.
Any
Okay.
confusion?
No.
No. So actually, this information is not very much important for part 2. I just for a better understanding, I take this picture.
Okay.
And this is autologous fascial sling. So what happened here? A sling is used. You can see this next picture, so you can understand. Look here, this is a sling. This is a mesh. What the mesh do? It goes around the urethra and like a sling and elevate the urethra. জাস্ট লাইক গলার মধ্যে যদি আমরা মাফলার পেঁচাই টান দিই যেরকম গলার সামনে চলে আসবে, ঠিক এই জিনিসটা এরকম সেই ইউরেথ্রার পেছন দিয়ে গিয়ে ইউরেথ্রাকে টেনে উপরে তুলে নিয়ে আসবে। সো দিস ইজ polypropylene mesh that we use in TVT or TOT operation, and the same thing we'll do by natural graft like fascia lata or rectus sheath. So this is autologous fascial sling and this is mesh TVT TOT, mid urethral sling. So all these things are not very important for part 3, just for understanding, I have taken these slides. So what is the summary? The summary is the surgical management of stress incontinence consists of colposuspension, either open or laparoscopic, autologous fascial sling, and retropubic mid-urethral sling. These are the simple surgeries. Now, what are the complex surgeries? Next is actually, this is not complex surgery. So this is not very much successful as the other 3. Another is intramural bulking agent and artificial sphincter. In Barch colposuspension, the success rate is almost 90%. Here we suture the paravaginal fascia or neck of the bladder to the Cooper's ligament. I already told. It is the gold standard. And autologous fascia sling, I already told you, with rectus abdominis or fascia lata we used, success rate around 85 to 92%. And the TVT-TUT, that is mid-urethral sling, the success rate in TVT around 80% and TUT around 43 to 95%. And what is the main complication here? In TVT, the main complication is bladder perforation and voiding problem, and TUT is less invasive, lower risk of bladder injury, however, may cause growing pain. So as a whole, the complications are mainly mesh erosion, hematoma, urinary retention, and de novo urgency. This part of information is required for part 2. Here, this picture shows the mesh, the picture of mesh, polypropylene mesh. This is type 1 macroporous polypropylene mesh. It is very important for part 2. This is given in the guideline, type 1 macroporous polypropylene mesh, and they considered to use it colored for high visibility and for ease of insertion and revision. And whenever we give mesh to a patient beforehand, we need to tell the patient some information we need to give that what are the benefit of the surgery, what are the adverse effect of the surgery, what is the so before surgery, in counseling, we will say the benefit and risk of all the surgical treatment. Uncertain is about the long-term adverse effects and the difference between the procedures. What is the success rate of all the surgical procedures? Which one is better? Which one causes what complication? All these things we need to discuss to the patient before the surgery. So now urethral bulking agent. What we will do here? If you look at the picture, you can see this will be done by the cystoscopy. And collagen or carbon-coated beads are injected in suburethral region. So what they will do, look, in stress urinary incontinence, the urethra become lax or relaxed, dilated, mobile. So if we inject the bulking agent here, look at the next picture, what they will do, they will compress the urethra. Thus, it will act like a sphincteric action. The benefit is it's minimally invasive and suitable for old, frail, elderly patient, and the side effects are transient urinary retention and patient may have urgency. And the limitation, what is the limitation? These materials are permanent and repeat injection may be required because the effectivity may wear off over time. So another injection may be required. And there is limited evidence on long-term effectiveness and adverse events. And the last resort is artificial sphincter. If all the treatment option has failed and the patient has bothersome, troublesome stress incontinence in that case, and whenever patient have previous surgery which has failed, in that case, artificial sphincter is offered, and this detail about this is not important. So this patient required postoperative follow-up and ensure access to review if needed. We already told artificial sphincter, why we will use in case of intrinsic sphincter deficiency and patient with failed prior surgery. Success rate though 90%, but there are chance of erosion, mechanical failure. So it will be only used in highly selected cases. So till now we have discussed about stress incontinence, what we have offered. Now what we will not offer, what the NICE guideline says, anterior colporrhea, needle suspension, and paravaginal defect.
ঠান্ডা লাগছে না ম্যাডাম হ্যাঁ একটু কম
Porcine dermis sling and
নাও ঠান্ডা লাগছে না ম্যাডাম
MMP procedure. We will not offer these surgeries, so we
গলা খুশখুশ
have a look on this. Now, after surgery, how we will follow up the patient? The follow-up will be within 6 months. And what we will see, whenever the patient come in follow-up, we will ask the patient whether her symptom has improved, whether the patient has any complication. Then we will examine the patient, whether there is any mesh exposure or extrusion. If there is any problem, in that case, the patient should be referred to the specialist. And this type of patient will be managed by or assessed by regional MDT. It is an important question. The question may come, like a question already came in exam in previous years. Patient of stress incontinence, TVT was done, now mesh extrusion occur. So what we will do next? So next is the patient will be referred to the regional MDT for further management. So if any question comes, then how to avoid surgery? Then what we will look for? We will look for pelvic floor muscle exercise, weight loss, topical estrogen, and pessary. So till now, we have discussed about the lifestyle modification, pelvic floor muscle exercise, the surgeries, but not any medication. So what about medication? Medication, according to NICE, it is the third line treatment, that is duloxetine. What is duloxetine? Only one medication for SUI. That is serotonin norepinephrine reuptake inhibitor. It increases the urethral sphincter tone. We already discussed the pathophysiology of urinary incontinence, stress incontinence. What happened here? There is no problem in the retrosal muscle, only the sphincter become mobile or relaxed. So they increases the sphincter tone. This is how they act. So the dose is 40 milligram twice daily for 3 months. This I have taken from the TOG article. And it is licensed in European Union for moderate to severe SUI, but not FDA approved. It is very much important. It is not FDA approved. And why it is not so popular? Because the effectivity is not so high, and the patient have very much difficult. Patient may have difficulties with bothersome side effect like nausea, dizziness, dry mouth, fatigue, and discontinuation rate is around 10%. So it is not recommended as first line by NICE. So why we will give this and when we will give this? If the patient is unfit for surgery or unwilling to go to surgery and patient wants medical management, in that case, we will give this medication. So what is the first line treatment or management of stress incontinence? The answer will be pelvic floor muscle exercise. What is second line? Surgical management. And what is third line? Duloxetine. This is a flow chart that we already discussed. I have told several times. Whenever patient come with stress incontinence, what we will do first, or what investigation we will do first? Urine dipstick. What management we will give first? Pelvic floor muscle exercise. And if patient is obese, weight loss. If failed, then surgery. The most important thing here, before advice for surgery, we need to send the patient for MDT. That is very, very, very much important. And if surgically unfit, in that case, duloxetine. This is the same thing. I have repeated several times for the easy memorization, because this information is very much important for the exam. The same thing, urine dipstick to exclude urinary tract infection. They categorize the patient, whether the patient is he is a patient of stress incontinence, then start treatment. First line PFMT, and if required, in that case, biofeedback or electrical stimulation if patient cannot do contract. How will you do pelvic floor muscle exercise training? 8 contraction 3 times a day for 3 months. Next, second line is surgery, corpus suspension. And what is the medical management? Duloxetine. And for all frail patient who cannot go for, if patient do not want to do surgery or patient is unfit for surgery, in that case, urethral bulking agent. And the last is artificial sphincter. This is the picture of some devices, that is, this is urethral plug and some continence spacery that we can offer to the patient when we can offer this patient whenever the patient is waiting for surgery. Patient have bothersome symptom, but patient is waiting for surgery. In that case, our patient is very much old, frail, unable to do any surgery, or is not able to taking the medication. In that case, we can offer devices. So I think we have done the stress incontinence. Now, few things about the non-surgical management of urinary incontinence. It is not for stress. It is as a whole urinary incontinence. NICE guideline says some absorbent contaminant product, urinals, and toileting aids we can offer to the patient as a coping strategy pending definitive treatment or as an adjunct to ongoing therapy. For long-term management of incontinence, only after treatment options, other options have explored. In that case, we review the patient once a year. This information is important. Review once a year. And what we will see, actually, this is not so much important. Just quickly, we will go through. We will check the skin integrity and whether there is any suitability of any alternate treatment and efficacy of the absorbent contaminated product the woman is currently using and quantities used. So other than absorbent product, what are the other non-surgical management? There are some catheter, either suprapubic catheter or Foley's catheter we can give, and some devices I have shown the picture earlier. And complementary therapies are not recommended. Here is they said in case of chronic retention, indwelling catheter can be given. Patient catheter can be given either intermittent self-catheterization, or indwelling catheter. Indwelling catheter given in persistent urinary retention. So catheter can be given either catheter. Asma, can you please mute yourself?
Yeah, ma'am, I can hear you.
No, you are mute. Please, you are not mute, Asma. Can you please unmute?
Oh, sorry. Yes, ma'am, I can hear you and I understand everything, alhamdulillah.
Noise are coming, I think, from your side. So can you please mute yourself?
Okay, ma'am, okay.
Okay, so we have finished the stress incontinence. Now, few slides about stress incontinence in pregnancy. This is from TOG article. The incidence of stress incontinence, actually it is not incidence, it is prevalence, that is 19 to 75%. And in pregnancy is itself a risk factor for incontinence, and vaginal delivery is associated with 8% higher risk of SCY. What is the cause? That is pelvic floor muscle weakness and urethral sphincter defect or incompetence. These are the causes. Other than these, high maternal weight, smoking, and constipation, these are also risk factors. So what is the first line management in pregnancy? The same thing, pelvic floor muscle exercise, supervised or structured pelvic floor muscle exercise. Now, how to manage? The treatment is same in pregnancy. However, surgical treatment is not actually offered to the patient with stress urinary incontinence. Few things you need to say to the mother that if she do surgery and if she again become pregnant, the surgery become failed. There are chance of failure of the surgery. So in that case, we will advise the patient to complete her family before the surgery. And mode of delivery usually do not appear to affect the SUA recurrence following surgery. So PFMT prevents and decreases the severity of SUA in pregnancy by increasing the strength of pelvic floor muscle. These are the other surgeries we are not going to discuss here. Now, postpartum stress urinary incontinence. It occurred in 4% of women after cesarean section, and this was a previous exam question. So what we will ask to the patient whenever a pregnant patient come, or if the patient want to become pregnant, so she come for the incontinence surgery, what we will ask the patient? We will advise the patient to complete the family before surgery. Now the patient did the surgery. Now she already became pregnant. Then what will be our next advice? So we will ask the patient whether she is having incontinence problem or not, whether she is symptom free or not. If the patient have done the surgery and it is successful, now patient is symptom free and she is pregnant, now we will tell the patient to go for cesarean section. The patient had surgery, but she is symptomatic. The surgery was not successful and she is pregnant. Now we can consider her to do vaginal delivery. Am I clear so far? And if incontinence recur or persist in postpartum period, the patient will wait for 6 months to 1 year, because recovery time sometimes required take 1 year or 6 months. And the efficacy of colpoid suspension is 81% after first procedure, 25% after second, and 0% after third surgery. So the first attempt is the best. So now we are going to urge incontinence. If anyone have any question regarding the stress incontinence, you can message me. So I will try to give you answer. Now, urge incontinence. We already discussed what happened in urge incontinence. Here there is involuntary, uncoordinated retrograde contraction, and there is no sphincter problem. So what is the management? First, like stress, here also lifestyle modification. These are modified the fluid intake, weight loss, reduced caffeine, So after the lifestyle changes, second line is behavioral therapy. Actually, this is not second line. All these are first line management. What is behavioral therapy? That is bladder retraining, and it will be done for 6 weeks. So PFMT for 3 months, bladder training for 6 weeks. Bladder training is also like PFMT. Whenever the patient do PFMT, and we advise to continue the treatment with other treatment modalities if she go for surgery or go for medical management. So like this, the behavioral therapy also need to be continued with further management, like if the patient take OAB medication. Other non-surgical management are bladder training, as we already told. Others are antimuscarinic drug, intravaginal estrogen, and desmopressin for noxuria. And we should not forget to send the patient to MDT before surgical management. What are the surgical management? Surgical managements are intravesical botulinum toxin A, sacral neuromodulation, posterior tibial nerve stimulation, and the most invasive surgeries are augmentation cystoplasty and urinary diversion. So what we have told till now, whenever a patient comes with OAB, first we will do urine dipstick to rule out urinary tract infection, because UTI symptoms, patient with UTI sometimes may present with symptoms of urinary incontinence like leakage. And we will offer her maintain a bladder diary. After that, whenever you confirm the diagnosis, what we will do, we give her lifestyle changes, that is, avoid tea, coffee, alcohol, modify the fluid habit, take 1.5 to 2 liter fluid daily, and restrict her from fluid intake 4 to 5 to 6 hours before going to bed. And weight loss if BMI is more than 30, and bladder retraining for 6 weeks. These are the non-surgical primary management of OAB. You have to memorize it by heart. Now, what are the medical management? These are the non-surgical management. Next, what are the medical management? Medical management are OAB drugs. These are anticholinergic drugs. So before going to prescribe the anticholinergic medication, we need to advise the patient we need to inform the patient few things. What is the likelihood of successfulness of this medication? What are the side effects? Dry mouth, blood vision, constipation. These are the common side effects of all anticholinergic medication. And how long the patient will wait for see the benefit. It will be at least 4 weeks. And long-term effect of these drugs on cognitive function. So before offering the medication, we have to check whether the patient is taking any other anticholinergic medication. In that case, there is load of risk of adverse effect, including cognitive impairment. And we will check whether the patient has any worrying dysfunction. Coexisting conditions like poor bladder emptying and cognitive impairment or dementia we should look for. And you may have question from this. The patient come with urinary incontinence, the patient have cognitive impairment. So it will give you a clue for diagnosis. So what we will not offer to this patient? Flavoxin, propenthelin, or imipramine. We will start the medication with the lowest dose. So we will avoid the side effect. If the patient is not improving with the lowest dose, then we can increase the dose. Or if the patient cannot tolerate the medication, in that case, we can change the medication. What are the drugs? There are 3 first-line medication: oxybutynin, tolterodine, derifenacin. Oxybutynin is M1, M3 receptor antagonist. Tolterodine is non-selective anticholinergic, and derifenacin is highly selective M3 receptor antagonist. So this M3, as it is highly selective, it is better. However, the most common is oxybutynin, and it is widely available and widely used drugs. Regarding oxybutynin is found in 2 forms, either immediate release or transdermal. So immediate release oxytocin we will not offer in older women more than 65 years. Why? because they're at high risk of sudden deterioration in the physical and mental health. So what we will do in old patient, we will offer them transdermal OAB. If first-line medication for OAB or mixed incontinence is not effective or well tolerated, what we can do, we can offer another medication with lower cost. So this information I have taken from the TOG article. Here, this says the successfulness of the oxybutynin is more than 50%, and the side effect dry mouth, blurred vision, constipation. And for this side effect, the discontinuation rate is up to 25%. And what is the side effect of transdermal route? Transdermal route, they causes pruritus at the skin when it is where it is given. Now, tolterodine, that is non-selective, I told you. And the terifenacin, that is highly selective M3 receptor antagonist. The side effects are same for all the medications. What are the precautions or caution? In case of autonomic neuropathy, hiatus hernia, hepatic and renal impairment, hyperthyroidism, coronary artery disease, heart failure, arrhythmia, in these cases, we have to prescribe this medication with caution. We can give, but with caution. And where we cannot give, what are the contraindications? These are myasthenia gravis, glaucoma, significant bladder outflow obstruction or urinary retention, severe ulcerative colitis, and GIT obstruction. Why we cannot give this medication? This anticholinergic drug, what they do? They causes relaxation of the bladder muscle. So the relaxation of the smooth muscle. For this reason, in case of bladder outlet obstruction, if the bladder become more relaxed, it will worsen the condition. So for this reason, we cannot give in these conditions this medication. These are the contraindication, and we have to memorize this. You may have question from this in exam. Now, medical management of OAB. What are the other medicines? So the first-line medication we have discussed. Desmopressin we can use for nocturia, the NICE guideline says. However, in case of cystic fibrosis, we have to use it with caution. And in case of age more than 65 years with cardiovascular disease or hypertension, we should avoid. The next medication is mirabegron. According to NICE, it is second line actually. However, as a first line in clinically, we actually use it. That is beta-3 adrenoceptor agonist. So we have to learn whatever the guideline says. Other than guideline, we cannot say anything. So what they do, mirabegron, that is as it is beta-3 agonist, it causes relaxation of the bladder muscle. And the common adverse effects are tachycardia and urinary tract infection, and uncontrolled hypertension is the main contraindication. What we will not given, systemic estrogen. Estrogen is another important medication. We will offer intravaginal estrogen for OAB symptom in postmenopausal women to increase the integrity of the vaginal mucosa. But we will not offer systemic estrogen because it may worsen the condition. So we will give medication. Now, how we will follow up? We will follow up every 4 weeks, either face-to-face or telephone review. And it is a very important exam question. It already came in the exam previously. If the woman is satisfied with the treatment and improvement is optimal, so what we will say to the patient? She will continue the treatment during follow-up. But if the condition is not improved or suboptimal improvement or intolerable side effect, in that case, we can change the medication and ask them to come again after 4 weeks. So if the patient, after that, if the patient is not improving, then we'll refer the patient to the secondary care. And if it is successful, then we will send the patient with the treatment and ask them to come after 1 year. What are the contraindications of anticholinergic drugs? We already told myasthenia gravis, bladder outlet obstruction, ulcerative colitis, GIT obstruction, and for mirabegron, severe hypertension. So this is the flow chart of OAB management, medical management of the OAB that we just discussed. The 3 medication, oxybutynin, tolterodine, derifenacin, and we will follow up after 4 weeks. If improved, they will continue the medication and follow up after 1 year in case of age less than 75, and after 6 months if age more than 75. If the patient does not improve or cannot tolerate the medication, in that case we can change the medication and again review after 4 weeks. If there is complications or side effect to the oral medication, in that case transdermal patch, and the second line is mirabegron. So now OAB with pregnancy. So we already have seen that pregnancy has effect on stress urinary incontinence. However, there is no strong association between OAB and urinary urgency or OAB with parity or pregnancy. And the prevalence of lower urinary tract reduces 6 weeks after childbirth. 41% patient may have OAB-like symptoms during first trimester of pregnancy, and 16 to 31% may have urgency during pregnancy. There are no specific treatment guideline for OAB in pregnancy, but treatment can be extrapolated from NICE guideline. Actually, the treatments are same in pregnancy. The lifestyle modification, pelvic floor muscle training, bladder retraining, anticholinergic medication. So these medications can be offered, can be given in pregnancy and breastfeeding. But we need to inform the patient that there is inadequate safety data for use in pregnancy, and in breastfeeding lactation suppression may be noted. And intravaginal estrogen, they can be used postnatally. Botulinum toxin is not commonly advised in pregnancy, as there are chance of frequent urinary tract infection as it causes urinary retention, and sacral neuromodulation is not offered during pregnancy. So this information are from talk article. And sacral neuromodulation, the effect of sacral neuromodulation on pregnant uterus is not known. And studies have showed no fetal abnormalities or fetal or pregnancy losses associated with sacral neuromodulation. So prevalence of all lower urinary tract symptoms reduces 6 weeks postnatally. And management is same as non-pregnant women. And long-term incidence of SUI symptom is higher, as well as in vaginal deliveries compared to cesarean section. So I think we already discussed all these things, and we have finished the medical management of urge incontinence. Now I would like to take a short break for the Maghrib prayer, then we'll come again. Thank you. Shall I start? So far, we have completed the medical management of OAB or urge incontinence or detrusor overactivity. Now the invasive management of overactive bladder. What are the invasive management of overactive bladder? Botulinum toxin type A, sacral neuromodulation, posterior tibial nerve stimulation, and the aggressive treatment surgeries are augmentation cystoplasty and urinary diversion. So we are starting with the botulinum toxin type A injection. Botulinum toxin, what it do? It causes paralysis of the detrusor muscle. And when we will use it? Whenever a patient with OAB or mixed incontinence with urge predominance come, and they have given all the preliminary medications, that is lifestyle modification, medical management. However, the condition is not improving. The problems are bothersome. Patient wants to go for further management. In next step, in that case, we will offer botulinum toxin. However, before that, we need to do two things. One is refer the patient to the regional MDT, local or regional MDT, and urodynamics. These two things are very, very, very much important. Before giving botulinum toxin, consultation with the MDT and doing urodynamics. So, what NICE guidelines says, if OAB symptoms caused by DO not responding to surgical and other non-surgical or pharmacological management, offer botulinum toxin A after local MDT review. But if patient have OAB symptoms, but no detrusor overactivity, not responding to non-surgical management, in that case we can consider botulinum toxin. This is the major difference. If the OAB symptoms are associated with leakage, in that case we will offer botulinum. If not associated with leakage, only symptoms of OAB, no DO, in that case we can consider botulinum toxin, and that will be after post-local MDT review. So before going to give the botulinum toxin, we need to discuss the benefit and risk with the patient. The likelihood of partial or complete symptom relief. This may cause urinary retention as it causes bladder muscle paralysis. So patient may not able to void spontaneously. So what they need to do? They need to go for clean intermittent self-catheterization. So there are chance of recurrent urinary tract infection. What talk article says? This says there are chance of 10% chance of urinary retention and 20% chance of recurrent urinary tract infection. Now, what is the initial dose? The dose will be 100 unit. The initial dose is 100 unit. If the patient's condition is not improving with 100 unit, next we can give another 200 unit. So how will we follow up the patient? Follow-up will be after 12 weeks. So for bladder retraining, follow-up will be after 6 weeks. For the anticholinergic medication, follow-up after 4 weeks. And for botulinum toxin, the follow-up will be after 12 weeks. You have to memorize all these things by heart, and you can make a chart and write all these things together so you will not forget. Now, how it is given? It is given by cystoscopy under local or general anesthesia. It takes usually 20 to 30 minutes time. If local anesthesia is given, in that case with flexible cystoscope, it can be done as an outpatient procedure. So the botulinum toxin is mixed with 0.9% normal saline and with a fine injection. It is given 0.5 to 1 ml per site. Around 20 sites are given, the injection are given. This is picture of botulinum toxin, and here how it is given with a flexible cystoscope. As outpatient basis, it is given. And it is the site. This picture shows the site of injection. So all these are about botulinum toxin. Now percutaneous sacral nerve stimulation will offer after MDT review. All the invasive procedures should be offered after MDT review. When we will give, if all other medication has failed and patient is not willing to have botulinum toxin or will not accept the side effect of botulinum toxin, that is self-catheterization, in that case we can offer percutaneous sacral nerve stimulation. And will not offer transcutaneous sacral nerve stimulation or transcutaneous posterior nerve stimulation. And will offer percutaneous posterior, we have told about sacral. Now posterior tibial nerve stimulation only after local MDT review, the same thing. And if the woman does not want botulinum toxin or percutaneous sacral nerve stimulation or non-surgical management has not worked adequately, in that cases only we will offer percutaneous posterior tibial nerve stimulation. This picture is showing sacral nerve stimulation. So a small incision is given here and a few inches above the coccyx near the sacral S3 sacral foramina, and the electrode is inserted temporarily. So how will we understand that it has correct placement? So it is confirmed by the levator muscle response, levator response, plantar flexion of big toe, and stimulation of perineal sensation. Basic evaluation can be carried out for up to, and bladder diary is kept to evaluate symptoms pre-procedure and during the test phase. And success is usually taken as an arbitrary minimum of 50% improvement of symptoms. So if there is 50% improvement of symptoms, so it is successful. In that case, we will follow and we will do permanent placement. And it will work for 3 to 5 years after implantation. So what is the main difference between the sacral percutaneous and transcutaneous sacral nerve stimulation? In percutaneous sacral nerve stimulation, the needle is inserted through the skin, means after opening the skin, given an incision, it's minimally invasive, the device is inserted, it is subcutaneously inserted. However, in transcutaneous, it is placed over the skin, so it is non-invasive but less effective. However, the percutaneous sacral nerve stimulation is more effective and minimally invasive. Where the percutaneous posterior nerve stimulation and where the electrode is inserted, it is 4 to 5 centimeters superior to the medial malleolus of the ankle. And initial treatment consists of 12 weekly session lasting for 30 minutes. Actually, all these details are not important for part 2. This picture shows percutaneous posterior nerve stimulation. Only botulinum toxin is very much important. This nerve stimulation only for your understanding, it is not so much important. And the last treatment, augmentation cystoplasty and urinary diversion. What is augmentation cystoplasty? We know in OAB, the bladder capacity has reduced, the bladder size became reduced. So patient cannot hold urine. So what happened here, part of bowel is used to increase size of the bladder. That is augmentation cystoplasty. That is bladder muscle, bladder size is increased by adding portion of bowel. So guideline says restrict for management of idiopathic datus overactivity in case of if patient is not responding to non-surgical management and are willing to or unable to self-catheterize. What are the complications? These are important. Bowel disturbance, metabolic acidosis, mucus production, and retention of urine, urinary tract infection, urinary retention. These are the complications of augmentation cystoplasty, and there are small risk of malignancy in augmented bladder, bowel part of the bladder. This patient required lifelong follow-up. So before going for augmentation cystoplasty, all this information should be disclosed and discussed with the patient that this complication can happen and lifelong follow-up is required. And the last resort, urinary diversion, these also required lifelong follow-up. These are not so important. So now we will summarize the OAB, management of OAB symptom. First, we'll do urine dipstick and bladder diary. Then after confirmation of the diagnosis, advise her to avoid caffeine, modify the feed intake, weight loss if BMI more than 30, and bladder retraining for 6 weeks. Now, if her condition is not improving, we will add along with this the anticholinergic medication. Anticholinergic medications are oxybutynin, dalterenib, dorithromycin. If the condition not improve, along with it, we will go for invasive procedure, that is botulinum toxin, nerve stimulation, sacral or posterior nerve, and the last resort, augmentation cystoplasty and urinary diversion. So these are all about OAB, the same thing here. So if you have any question, you can message me or you can ask me in next class. So I have several questions for you. So as you are not there, so I am passing these slides. Now I'm starting urodynamics. What is urodynamics? These are dynamic tests of lower urinary tract. There's a set of tests to measure the function of lower urinary tract. And what ICS say, ICS is International Continence Society. They says all the measurements that assess the function and dysfunction of lower urinary tract by any appropriate method, including cystometry and pressure flow studies. And what are the components of urodynamics? Uroflowmetry, cystometry, pressure flow study, urethral pressure profile, and electromyogram. These are the components. You have to know about all the components, but you have to know detail about this. Only the uroflowmetry and cystometry you have to know. All the rest of the things are not required for part 2. What is uroflowmetry? Here we will measure the flow of urine. It is a non-invasive test, and cystometry is an invasive test. We already discussed the indication of the urodynamics, so I am passing these slides. Now, what are the prerequisites for urodynamics? Before going to do urodynamics, as it is an invasive test, so we need to discuss with the patient about detail of the test, what we will do. So we should have a comprehensive history regarding her conditions, her urinary symptoms, what type of symptoms she is, whether the patient is having stress symptoms or arch symptoms or mixed symptoms, and for how long the patient is having these symptoms and whether these symptoms affect on their quality of life. Now regarding her past history, whether the patient has any previous surgery like any incontinence surgery, and her obstetric and neurological history are important, whether the patient has any neurological disease or diabetes. Now, another important thing is the medication history. Medication history is very much important, and a question can come from here in exam. Whether the patient is taking any diuretics or any antihypertensive drugs, the question can come, what medication can cause symptoms of stress incontinence? So, antihypertensive alpha blocker, they act on the sphincter and make the sphincter relax. So, they can cause stress urinary incontinence like symptoms. So, they like this way, a question can come in exam. And whether the patient is taking any diuretics or any cholinergic medication. So, this much information is very much required before going for a urodynamic test. Then examination, abdominal and pelvic examination to see the condition of the muscles of the pelvic floor, whether their patient is having any infection, any signs of infection, any prolapse or mass, quality and contractility of the pelvic floor muscle, and any leakage with straining, and urological examination is important. And the other things are bladder diary and urinalysis and patient information leaflet. I already told that patient should be given all the information of that test. So, for preparation of the patient, what is the latest recommendation? If the patient is taking any anticholinergic or antimuscarinic drug, any cholinergic drug, shall we stop the medication? So the latest recommendation is, it's the clinician's choice whether the medication will stop or not. Now, the urine dipstick. Urine dipstick must be done before urodynamics to rule out any infection, and if there is any urinary tract infection, this should be treated earlier. And should prophylactic antibiotic given to all the patient who will undergo urodynamics? The answer is no. Prophylactic antibiotic is not required or not a prerequisite for urodynamics. And if the patient is having any prolapse, that should be reduced either using a pessary or using finger before doing urodynamics. So what NICE recommends? We already know before urge incontinence, when we will go for urodynamics, if we already discussed, if we advised the surgical management of urge incontinence, in that case, before going to surgery, we must do urodynamics. In case of stress urinary incontinence, pure stress incontinence is not an indication for urodynamics. However, if the patient has associated voiding dysfunction, anterior compartment prolapse, or previous surgical history, in that case, we will offer stress urodynamics. Now, uroflowmetry. What is uroflowmetry? That is urine flow study. We will assess how much urine the patient has passed per unit time. It is uroflowmetry. That is volume by time. It is the first line screening test for voiding difficulties. So by uroflowmetry, we will check the voiding difficulties. The patient is asked how it is done. The patient is asked to void over a chair that contain a uroflow meter. And the patient should be relaxed. We'll ask the patient to relax, not to strain while sitting on a commode over the rotating disc flow meter. This chair and this commode contain a flow meter. And we will record the volume of urine she passed per unit time, and it is assessed in expressed as milliliter per second. Whenever the patient void and there is electrode and computer is attached with it, and here we will see a graph. We will measure the rate, volume, duration, and pattern of urination. This is uroflowmetry. This slide is very, very, very much important for exam. What we will found? We will check the amount of urine she voided, that is the voided volume, and the time required, that is flow time required to void completion of the void flow time, the pattern of flow, the maximum flow rate and time to maximum flow, that is TQ max, average flow rate, and last of all we will do a PVR, post void residue. Now if you look at this picture, this is a graph of uroflowmetry. This is a typical bell-shaped graph, and the total area of graph, the total area inside the graph is the voided volume, and the time required from starting to end of the graph is the flow time. The normal flow time is 15 to 30 seconds, and the maximum flow rate, and this is the Qmax. Whenever it is the highest height of the graph, it is the maximum flow rate, and the time required for it is the time to maximum flow. So the Qmax is 25 ml per second, and the range is 20 to 36. You have to memorize it. If you do not memorize all these things, you cannot interpret. It will be very difficult for you to interpret urodynamics. The Qmax is 25 ml per second, and the range is 20 to 36. And the time for and the flow time is 15 to 30 seconds. The peak flow rate more than 50, and residual volume less than 50 ml, and sometimes less than 100 ml also, it is acceptable. How will be normal bell-shaped graph? Normal graph will be bell-shaped, as I told. Then what is bell-shaped? A rapid upstroke, then a continuous curve flow, a clear maximum flow rate, and a quick decline to end cleanly. This is the bell-shaped curve. This is a picture of bell-shaped curve. Here we can see in this picture, the Qmax is 24. So we know the normal Qmax is 20 to 36. So it is normal. It is a bell-shaped curve. Here the voided volume is around 250. So it is a normal uroflowmetry. So what we are going to see in uroflowmetry? Voiding dysfunction. Why voiding dysfunction occur? I already discussed the physiology of the bladder, that is micturition cycle. So for voiding, detrusor muscle need to be contracted and sphincter need to be relaxed. So voiding dysfunction occur if the detrusor cannot contract. Detrusor contractility dysfunction and urethrosphincteric dysfunction, or bladder outflow resistance, or any obstruction by just like with prolapse or any mass. If there is bladder outflow resistance or obstruction, this can cause voiding dysfunction. PVR less than 100 is not regarded as clinically significant in asymptomatic patient. High PVR where we will found in case of detrusor underactivity or failure, anticholinergic medication, or bladder outlet obstruction. So we have seen the uroflow pattern. This is the normal bell-shaped pattern, normal flow. Here we can see Qmax, time to Qmax, and the flow time. So if we found this type of curve, that is a reduced Qmax, a continuous flow for a prolonged time, this it indicates prolonged flow, obstructed or weak bladder. Here the talk article also this says This type of prolonged flow we will found where, in case of stricture urethra, external urethral compression or bladder outflow obstruction, like with prolapse or falling continence surgery or failure of bladder neck relaxation or a contractile bladder. You have to memorize it if you want to understand or interpret the uroflow. In that case, you have to memorize these things. What is the, how is the normal flow, normal uroflowmetry curve, and what indicates in case of reduced Qmax, prolonged Qmax. So reduced and prolonged Qmax indicates obstruction or weak bladder. So whether it is obstruction or weak muscle, detrusor muscle, how we can understand? For understanding it, we need to do cystometry. And here, this type of curve, this is intermittent flow. Stops, the flow stops and starts, stops and starts. This is intermittent flow. So intermittent flow we will found on unsustained detrusor contraction, that is in case of abdominal straining or detrusor sphincter dyssynergia. Here, this picture we can see here is reduced Qmax and continuous prolonged Qmax. In case of cystocele, which causes urethral kinking, we can found this type of uroflowmetry. Here it is the intermittent flow. This flow pattern also abnormal as the flow is intermittent. Urine here stops, urine stream stops and starts. Again, this may be due to obstruction or hypocontractile bladder. Abnormal flow pattern indicate warning difficulty, which increases the risk of retention after incontinence surgery. This picture, the first one, is a normal bell-shaped curve. And in this one, B, number B, A is normal curve. B, here we can see reduced Qmas and reduced and prolonged Qmas. And in C, we can see the intermittent flow. This urine stream starts and stops. In number D, we can see the fluctuating flow. And in E, here rapid upstroke, rapid downstroke. So hypercontractile bladder. I hope you are clear about uroflowmetry. So if you are clear, then we will go for cystometry. Cystometry is a core test of urodynamic investigation. In cystometry, it is the continuous measurement of the process of the pressure of the bladder and the relationship of the bladder to assess the sensation, detrusor activity, bladder capacity, and bladder compliance. What is the aim? To reproduce the symptom of incontinence. How we reproduce? In cystometry, what we will do? It is an invasive procedure. So what we will do? We will fill the bladder with some normal saline or via catheter. So whenever the bladder becomes filled, patient will feel urge. She feel like her bladder is full, and we will check how much or what type of symptoms the patient is having. So we are reproducing the symptom artificially. So this is the cystometry. Here is the cystometry chair. So in this picture, we can see two catheters inserted inside the bladder, one for filling the bladder with saline, and another to measure the intravesical pressure, and another catheter inside the vaginal rectum to measure the intra-abdominal pressure. So intra-abdominal pressure is measured and it is expressed as P-abd, vesical pressure by P-ves, and detrusor pressure by P-det. So by this catheter through transducer, we will measure the abdominal and vesical pressure. However, we do not have anything to measure detrusor pressure. So how will you measure the detrusor pressure? If you look at this picture, this is the abdominal pressure, and this is vesical pressure. You can see whenever there is raised intra-abdominal pressure, this pressure also transmits inside the vesicle as the bladder is inside the abdomen. Okay, so whenever abdominal pressure rises, vesical pressure also rises, and vesical pressure is the sum of abdominal pressure and detrusor pressure. So if we deduct the abdominal pressure from the vesical pressure, we will get the detrusor pressure. I hope you are okay now. So for interpretation of the cystometry, all these things you have to memorize by heart. What is the bladder capacity? Normal capacity 400 to 600 ml. First desired to void 152 to 200 ml. Detrusor pressure during filling less than 15 centimeter of water, and during voiding less than 70 centimeter of water. If the detrusor pressure during voiding is more than 70 centimeter, in that case, we have to think that there may be some obstruction. Then peak flow rate, we already discussed, it is more than 15 ml per second. Flow time 15 to 30 seconds, Qmax 20 to 36 ml per second, and residual volume less than 100. And normal vesical pressure is 5 to 50 centimeter, abdominal pressure also 5 to 50 centimeter, detrusor pressure 5 to 15 centimeter during filling and 70 centimeter during voiding. This slide is very, very much important. In this picture, what we can see, this is vesical pressure, this is abdominal pressure, and this is detrusor pressure. Whenever we will interpret any urodynamics graph, means systometric graph, first of all, there is a rule. The rule is, first of all, we will look for detrusor pressure. If detrusor pressure is normal, there is no rise in detrusor pressure. In that case, we will rule out detrusor overactivity. So, rising of abdominal pressure associated with rise of vesical pressure indicate what it indicate. If it is associated with leak, then it indicate stress urinary incontinence. However, if it is not associated with leak, it is normal urodynamic stress study, no stress incontinence. Am I clear? So this graph, here we can see rise of abdominal pressure associated with rise of vesicular pressure and no rise of detrusor pressure, and there is no leak. So this is a normal urodynamic test, normal cystometry. We already told all these things. So few things we need to check during filling. So what we will do here, during this test, we will, where is the picture? So during this test, whenever we put catheter, this catheter and we will fill the bladder with fluid, we will ask the patient to check, to tell them when she feels desire. First, feels sensation of something inside her bladder. So this is first sensation of filling. What is first sensation of filling? The moment the patient feels that their bladder is no longer empty, it is first sensation of filling. Then first desire of void. The moment the patient normally tell the patient that I will go to the toilet without any hurry. She's feeling urge of urination, but not in any hurry. So this is first desire to void. What is strong desire to void? When the patient will not wait, she will wet herself. This is strong desire to void, and it is equal to maximum cystometric capacity. The patients may additionally report sensations like feeling of urgency, fear of leaking, or pain, or any other symptoms. In this graph, it is in this cystometric graph, whenever we interpret any graph, first what we will see, first we will look where it is. The graph has this page. So whenever we interpret any graph, the graph has two parts. One is filling and another is voiding. The first part is filling phase. This part is filling phase and this part is voiding phase. So the recording during filling phase is basically called cystometry, and the recording in voiding phase is called pressure flow study. And what are the rules? In normal circumstances, P date will be 0. In a normal patient, whenever we do a cystometry in filling phase, we will never get any detrusor pressure in normal patient. So in normal patient, the detrusor pressure will be 0. So for this reason, whenever we interpret an urodynamics for cystometry, first we will look at the detrusor pressure. And during cuff also, the detrusor pressure will be 0. If there is any spike in PDAT, it will be mirrored in PVES also. As we know, PVES is the combination of PDAT and PABD. So if there is any rise in PDAT, PVES also rises. And this is detrusor overactivity. And if it is associated with leak, in that case, we will call it arch incontinence. This much of knowledge is very much important. Otherwise, we will not able to interpret urodynamics. Here in this slide, we can see, if you look at this picture, if there is rise of abdominal pressure associated with PABD, associated rise of PABD, associated with PVES, but no rise in PDAT, this is stress incontinence. It must be associated with leakage. If there is no leakage, then it is normal urodynamic study. And if in case of detrusor overactivity, rising of PDAT associated with PVES, no rise of PABD, this is detrusor overactivity. And if it is associated with leak, it is arch incontinence or detrusor overactivity incontinence. So if we look at this graph, here rise in abdominal pressure on provocation, cough. Look here, here the patient is coughing. So during cough, there is rise of abdominal pressure, rise of vesicular pressure, but no leak. So this is a normal urodynamic study. So corresponding peak of abdominal pressure with vesical pressure, but no rise in PDAT associated with leak is the urodynamic stress incontinence. You have to memorize it. Rise in abdominal pressure and vesical pressure, but no rise in PDAT associated with leak is urodynamic stress incontinence. This is again a picture of urinary incontinence. Here, this is the abdominal pressure, this is vesical pressure. So in feeding phase, abdominal pressure rises with vesical pressure also, but no rise in detrusor pressure. And here is leak. So it is a graph of urinary stress urinary incontinence. We have discussed earlier what is stress incontinence and what is urodynamic stress incontinence. Now, what is overactive bladder? What is detrusor overactivity? We also told it earlier. If no urodynamic study, only OAB symptom, it is OAB if associated with the urodynamically proven detrusor overactivity, means you will find PDAT raised, it is detrusor overactivity. However, it can be provoked or unprovoked. What is provoked and what is unprovoked? You all know unprovoked means no provocation. But what is provoked detrusor overactivity? I'm showing you. Here, this slide shows, we already discussed, I'm again telling random contraction of detrusor muscle when bladder is filling and showing abnormal peak in detrusor line in systometry. Nothing will happen in PABD. As PVES is the sum of PABD and PDAT, so we'll get a corresponding peak in PVES. Spike in PDAT and leak in feeding phase is associated with the OAB. We already told this. The first arch in around 200, first sensation around 100, and strong arch around 500, we already discussed. So what is detrusor overactivity? We already discussed rising of vesicular pressure associated with rise of detrusor pressure, no rise in abdominal pressure associated with leak. Here we can see this is PDAT. So rising PDAT associated with PVES, but no rise in PABD. So this is a case of DO. Here we can see rising the PVES associated with PDAT. Along with it, this is leak. So this is detrusor overactivity incontinence. If there is no leak, this is only detrusor overactivity. If there is leak, it is detrusor overactivity incontinence. Now there is urethral pressure profile. I think all these things are not required for part 2. So I'm going through these slides, and video urodynamics and ambulatory urodynamics, these are also not important for part 2. You just know the name. And one thing that if the simple urodynamics is not conclusive, it is inconclusive or is not helping the patient to make the diagnosis, in that case, we will go for video cystometry or ambulatory urodynamics. So I had few questions. I'm not telling this today. You all should go through this lecture and go through the guideline. And if you have any question, in that case, we will discuss in the next class, or we can discuss this question in the next class. Now, a few things about the talk article. Recurrent urinary tract infection. What are the symptoms? The symptoms are similar as UTI, dysuria, urinary frequency and urgency, and the symptoms of UTI during pregnancy is around 8%, which increases up to 25% if patient has associated asymptomatic bacteriuria. And the symptoms of pyelonephritis in pregnancy is 2%. You just memorize it. Incidence of pyelonephritis in pregnancy 2%, UTI 8%. If associated asymptomatic bacteria, it is 25%. And if the patient have UTI during pregnancy, what are the complications that can happen? It can cause preterm birth, stillbirth, chorioamnionitis, and small for gestational age. The first-line investigation for diagnosis of UTI is urine dipstick or urine analysis. If urine dipstick or urine routine examination is positive for infection, in that case, urine culture, we all know it, and the most common pathogen E. coli in 80% cases. What is recurrent UTI? 3 or more episodes of UTI in 1 year or 2 or more episodes in 6 months is called recurrent urinary tract infection. This knowledge is important for part 2. So in 1 year or 12 months, if 3 or more episode of UTI, or in 6 months, 2 or more episode of UTI, it is called recurrent urinary tract infection when it is common in postpartum patients and postmenopausal patients. What are the main risk factors for recurrent UTI? Young age, less than 15 years, maternal family history, frequency of sexual intercourse, high parity, lower socioeconomic status, hydronephrosis, and renal stone. What is the treatment? Trimethoprim 100 milligram once daily, and it should be avoided in first trimester, and nitrofurantoin, which should be avoided in third trimester. This knowledge is very much important. So in first trimester, we'll advise trimethoprim. In first trimester, we'll avoid trimethoprim, and in third trimester, we'll avoid nitrofurantoin, and we can give amoxicillin and cephalexin, and local estrogen cream can be given. Now, recurrent UTI in pregnancy, how we will follow up this patient? Every fortnight or every 2 weeks till 36 weeks, and then weekly till delivery. Now, urinary retention. Postpartum urinary retention is a common condition, and the prevalence is 14.6 to 24%, that is around 20%. It may be covert or overt. What is covert? What is overt? When we see the patient is unable to pass urine within 6 hours of delivery, vaginal delivery or after removal of catheter in cesarean section, it is overt. And what is covered? Whenever a patient is not complaining of retention, but whenever we check PVR, we found PVR is more than 150 ml. This is covered urinary retention. What are the risk factors? Epidural analgesia, prolonged first to second stage of labor, instrumental delivery, episiotomy, primiparous women, physiological changes such as increased progesterone level. I think this is the last slide. So in case of postpartum urinary retention, how will we manage? First, we will do an in and out catheter to check the residual volume. If it is 150, less than 150, it is normal. If it is more from 150 to 250 ml, then what we will do? We will proceed attempt at second void at 6 hours post catheter removal. That is, we will give her another chance to void after 6 hours. If the residual volume is 250 to 700, in that case, we will insert a catheter for 24 hours and give a trial of removal after 24 hours. If it is more than 700, then what we will do? Then we will give her indwelling catheter for more than 2 weeks. So this is very much important, this table. You may have a question from urinary, postpartum urinary retention. You know, this urinary tract infection, recurrent UTI, urinary retention, these are very paid subject of RCOG. They very frequently give question from this. So in case of urinary retention, we will check PVR. If it is less than 150, it is normal. If it is 150 to 250, we will do in and out catheter and ask the patient to void again after 6 hours. And if it is 250 to 700, we will give catheter for 1 hour, then do again trial of removal. And if it is more than 700, then ask the patient to give the catheter for 2 weeks, ask the patient to go home and come after 2 weeks, then do trial of removal. So this is all about the postpartum urinary retention. So far we have discussed today all the types of types and management of urinary incontinence, urodynamics, and recurrent urinary tract infection, postpartum urinary retention, and the urinary retention in pregnancy, and other related talk articles. Thank you all.